Okay, this is my head to toe video assessment submission. So I'm going to start by showing you all around me my environmental scan. My note card, front, nothing on the back. And I will have it sitting here on the counter or holding it so I can read it. Okay, let's get started. Okay, so the first thing I would do is hand hygiene. I would close the curtain or the door to provide for privacy for the patient and I during our head to toe assessment. And then I would introduce myself and say, hey, I'm Landis, I'm gonna be your nurse today. And then I would ask permission. Is it okay if we go ahead and do a head to toe assessment today to make sure everything feels, looks, and sounds the way it should? And hopefully they would give me permission. I would then ID the patient by their name and date of birth. So Landis Wigley, birthday 2/1/89. Okay? And then we would move on. Oh, and I would assist the patient into the appropriate position if they were not already there, and provide for safety in doing so and make sure they were safe at all times during this exam. Okay, so then we would assess the vital signs. We would do the radial pulse, which is located on the thumb side of your forearm. And we would count for 60 seconds and then record our pulse rate. Then we would keep holding the pulse while we counted respiratory breaths for 60 seconds, and then we would record that as well as their respiratory rate. Then we would move on to blood pressure, and we would place the cuff 1 to 2 inches above the brachial artery. We would go ahead and palpate the brachial pulse, and then we would inflate the blood pressure cuff 30 mmHg above where we hear the pulse stop, and that would be known as our systolic pressure. For the assessment today, we are just going to say that the blood pressure is 120/80, which is also a regular blood pressure. So then we're going to move on to respiratory. First, I'm going to place the patient in the appropriate position. I would say that I would want them to cross their arms across their chest for the lateral and posterior portion. But for today, we're just going to do anterior. And I would ask the patient to lay supine, and I would help get them into this position. For myself today, I'm only going to show you the anterior portion. So we would auscultate on 8 locations on the front, 4 locations to the right, and 3 locations on the left. And we would auscultate for 10 locations on the posterior side. So first, we're going to inspect the chest. There's no visible deformities. AP diameter is a 1 to 2 ratio. And the chest seems symmetric bilaterally, no superficial venous patterns, no lesions, and no melanoma is noted. We would go ahead and say that the respiratory rate was easy, without distress, and regular, and that everything sounded good. There were no adventitious sounds. Then we would go and move on to the chest expansion. It's going to be hard for me to demonstrate this on myself, so I'm just kind of going to show you. You would put your hands in this position on the patient's thorax around this area, and you would be wanting to look for chest symmetry and make sure that when the patient took a breath, that your hands came up the same bilaterally, and that there was no use of accessory muscles. Next, I would want to note that I didn't hear any adventitious sounds without my stethoscope. So that would include stridor or wheezing, and you could hear those as soon as you walked into the room with the patient. Then I would feel for crepitus, and I would go ahead and just feel around here, the top of the thorax. Crepitus sounds like crackling underneath the skin, and it's kind of like air trapped underneath the skin. And we would want to make sure that we didn't have any of that and document appropriately. Now I'm going to auscultate the lungs, or the breath sounds. As I said, there's going to be 8 in the front, 4 on the right, 3 on the left, and 10 on the posterior side. And I am going to use my diaphragm of my stethoscope. So excuse me, I hope I can show you good enough on myself. And I am going to do a stepwise side-to-side fashion. And you want to listen for 1 inhale and 1 exhale at each location. Okay, I want to note that I did not hear any stridor, wheezing, ronchi, or friction rubs when I listened to the anterior locations. And you would listen for those same sounds on the lateral and posterior portions as well. Okay, now we're going to move on to cardiac portion of this assessment, and we are going to start with pulses. So I am going to start by palpating my temporal pulses, and you want to do this bilaterally. And you are feeling for any bounding, any irregularities, which I do not feel. So I would say that my temporal pulses are regular, regular rhythm and rate with a 2+ amplitude bilaterally. Now we're going to move on to the carotid pulses. You want to do these 1 at a time, but bilaterally. You don't want to obstruct any blood flow, and you also don't want to reach over a patient because that could make them uncomfortable. So let's go ahead and start this side. No bounding, so rate and rhythm is a 2+ amplitude. Same on the other side, so you can say the carotid pulses are a 2+ amplitude bilaterally. Now you want to assess the radial pulses, which I did earlier, and you want to do this bilaterally as well, and you can do them at the same time, and you want to record that they are a rate and rhythm normal, 2+ amplitude bilaterally. Next, you want to assess the popliteal pulses, which you would want the patient to be in a prone position, but for this assessment, I'm not able to do that. So I'm just going to show you that you would reach back here and that you would record and document the popliteal pulses as being a regular rate and rhythm 2+ amplitude bilaterally. Next, you're going to do the posterior tibial pulses, which is about right here. You're going to want to do this at the same time. And you want to record that it's a normal rate and rhythm, 2+ amplitude bilaterally. And lastly, you want to assess the dorsalis pedis pulses, which you want to go down the big toe and kind of just fall into it. You want to do this at the same time, bilaterally, and you would say that it is a normal rate and rhythm with a 2+ amplitude bilaterally. Next, we're going to auscultate for bruits, which are any low-pitched sounds, and it kind of sounds like swishing underneath the skin. Okay. Oh, I'm sorry. Before we do that, I need to say that the patient's pulse rate, we'll just say was an 80 for today because I didn't take it. And I would say that that's in the normal range because bradycardic is 60 or less and tachycardic is 100 or above. And before I auscultate for Brewett's, we need to look for obstructed blood flow. So I would use the back of my hands and I would run my hands down the upper extremities and down the lower extremities. And I would record that the skin is warm, that there was no mottling or pallor. So that covers color. There is hair distribution evenly on the upper extremities and lower extremities. There is no edema. You want to check for capillary refill as well on every hand and both your feet. I can't do that because I have shoes on. You want the cap refill to be 2 seconds or less, and if it's more, then there is obstructed blood flow. You also want to ask the patient if they have any numbing or tingling. For this, we're going to say that the patient says no, there is no numbing or tingling. And also you want to check for elasticity and skin turgor. So you would just pinch the skin on both sides. And did I cover edema? If not, you're going to place your thumb and press and see if it comes back. If it stays down, like the skin stays down, you're going to want to look at your edema sheet and measure how far the edema is in the lower extremity. Oh, also for your nails, you want to make sure that there's no signs of clubbing and the nail beds are at 160 degrees. Okay, now we will auscultate for Brewett's. Okay, so I'm gonna assess the temporal, the carotid, the abdominal aorta, and the renal. And I'm gonna use my bell for this because these are low-pitched sounds. Okay. And for the carotid, you would ask your, and you would do bilaterally for temporal. You would ask your patient to hold their breath while you listen to their carotid for Brewett's. You would do the other side and ask them to hold their breath again. And then you could tell them they can breathe again. Okay, I do not hear any Brewett's in my temporal bilaterally, my carotid bilaterally, my abdominal aorta, or my renal aorta, or my renal arteries, sorry. Okay, so next we're just going to say again that the chest is symmetric, the AP diameter is a 1:2 ratio, there's no skin lesions, no apparent venous patterns, everything looks symmetric. Okay, now, the PMI is at the 5th intercostal space on the left. Right, yeah, left. So 5th intercostal space on the left, midclavicular line, which you can see is about right here. Okay, so now we are going to auscultate for heart sounds. Okay, so I'm going to use the diaphragm of my stethoscope first, and then I will repeat the entire process with the bell of my stethoscope. Okay, I am going to start on the right side at the second intercostal space, and I'm going to listen to the aortic valve. Okay, I'm going to listen to the second intercostal space on the left, which is the pulmonic valve. I'm going to listen to the third intercostal space on the left, which is Erb's point. I'm going to listen to the fourth intercostal space on the left, which is the tricuspid valve. And the fifth intercostal space, midclavicular line, which is the mitral valve. Good. Now I'm going to repeat this process with the bell of my stethoscope. Second intercostal space on the right, which is aortic valve. Second intercostal space on the left, which is the pulmonic. Third intercostal space on the left, which is Erb's point. Fourth intercostal space on the left, which is tricuspid. Fifth intercostal space, midclavicular line, which is mitral. Good. With the bell and the diaphragm, I heard both S1 and S2, which are the lub-dub sounds, and I did not hear any S3 or S4, which are the murmur sounds. If I did hear any murmurs, I would hear systolic stenosis with my bell, and I would hear diastolic regurgitation with my diaphragm. And if I needed to hear these sounds more clearly, I would ask the patient to lean forward or lean to their left. Okay? Okay, now, great. We are moving on to the abdomen. So I would put the patient in the dorsal recumbent position, but since it's just me, I'm going to be demonstrating on myself. So, but if it was a patient, we would be in dorsal recumbent position. I would expect the patient to be relaxed, no guarding postures, comfortable, and not showing any signs of pain. So then I would say again that their skin is smooth, no signs of mottling or pallor, no masses noted, no visible peristalsis. And then I would ask the patient, if they were laying down, I would ask them to lift their head a little bit. That would make the abdominis rectus muscles protrude, and then you would be able to note any masses or hernias or separation in the abdomen area. Okay, so I would auscultate all the quadrants of the abdomen before I palpated for the purpose of not interrupting any bowel sounds. And also, if they have any pain in the quadrants, you want to be able to listen first before you put or inflict any more pain than they're already feeling on them. So we're going to go ahead and listen to the abdomen, and we're going to listen in the way of the digestive tract. So we're going to start at the left upper quadrant. Right, this is my left, yeah. Okay, so yeah, left lower quadrant, left upper quadrant, right upper quadrant, left, right, or right, left. Blech. Oh my gosh, I cannot talk. Okay, so we're going to do right lower quadrant first. left upper quadrant, upper right quadrant, and the lower right quadrant. And if I was doing this on a patient, I would want to spend a minute in each quadrant listening, but for the purpose of this, I don't have time, so I'm just going to demonstrate. I heard bowel sounds in all of the quadrants, and it was very frequent. And you want to document that. Okay. No bruits were previously noted on the abdominal aorta and the renal arteries, so that's good. I would now want to do a light palpation just to test for any muscle tenderness, any pain, or anything of the sort before I did a deep palpation. So I would kind of just, run my fingers over, see how the patient reacted. I would note that there was either muscle tenderness or no muscle tenderness, if I felt any masses or anything like that. Now we would do a deep palpation, and in the left lower quadrant, I would be feeling for the appendix, which here, and the patient would note any pain. And in this left upper quadrant, we're going to palpate for the spleen. The liver, the liver. And it shouldn't really be palpable, but it could be enlarged, and if it does, it could extend downward a little bit. Over here in the right upper quadrant, those are difficult to see on video, and then I'm doing it on myself, and I'm getting mixed up. You're palpating for the spleen here. You want to make sure, normally it's not palpable, but it could be enlarged and you could feel it then, but it should feel firm. And if the patient has any pain, that could mean that they had an infection or trauma to it in the past. And in this quadrant, you just kind of have intestines, and there's no major organs. Okay. Perfect. Okay, excellent. So now we would just want to ask our patient, how frequent are your bowel movements? When was your last bowel movement? Has there been any change in your bowel habits? What about pain or burning when you're urinating? What about leaking of any urine? Do you have issues with that? Do you have issues with digestion or past surgeries? And the last one is, do you have any abdominal pain or nausea and vomiting? And you would document that. If they said yes to any of those questions, I would use the Olcart's mnemonic to be able to get a better past health history of those issues that they would have. Great. Okay, let's move on to musculoskeletal. Yay. Okay, so first I would have the patient stand in front of me, and I would expect their thorax and their posterior, along their back and their vertebrae. I would say that everything looks symmetric. Their vertebral column is straight. There's no visible deformities, gross deformities, no swelling, no masses, no superficial venous patterns, anything like that. And you want to also say that the muscles seem symmetric bilaterally, and there's no fasciculations or spasms that you can note. Okay, so first we're going to palpate the muscles and also for heat, any swelling, tenderness, pain, anything of that sort. So first we're going to start with the temporomandibular joint. Excuse me, I do have degenerative discs, so if you do hear clicking, popping, or pain, that's why. You want to ask the patient to move their jaw side to side, front and back. And you would want to note any clicking, popping, or pain, and you also would want them to clench and feel their temporalis and masseter muscles. Okay, moving on to the cervical spine. First, you want to note that the cervical spine right here is concave, as expected. The muscle structure seems symmetric bilaterally. And then you would want to ask the patient to put their chin to their chest and palpate C7. I don't even know if you can see this. C7 and T1. Okay? And then we're going to test for the muscle strength. I would ask the patient to lean back for hyperextension, front for flexion, to the sides, and I would also ask them to rotate both sides, and I would apply resistance and ask them to try to turn. And that tests the sternocleidomastoid. And then I would put my hand on their forehead and ask them to press forward against resistance. That tests the trapezius muscles. And then I would put my hand on the back of their head, ask them to lean back. That tests the sternocleidomastoid. Well, it tests both of them. So we just want to note that the muscle structure and the strength is the same bilaterally. Okay, we're going to go ahead and palpate the hands and wrists. So what you want to do is just palpate all the joints and then over their hands as well. And you want to do this bilaterally. Everything seems good. Okay. So you would note that everything looks good. Excuse me. For that bilaterally. You also want to say that the hands appear symmetric and that they also have 5 digits on each hand. And you want to note if they don't either. So no nodules, tenderness, or heat that I feel. And you want to check that on the patient as well, obviously. But I am your patient, so. Okay, so to test for hand and wrist, flexion and extension, raise your fingers for hyperextension, down for flexion. This is opposition, pinky to thumb, adduction, abduction, and you can wave for ulnar and radial motion. And you want to do the same on the other side as well. And for the wrist, you want to flex and hyperextend. And you want to note that everything is symmetric. Muscles are a 5 out of 5. We'll go ahead and palpate the elbow and for any tenderness, heat, nodules, pain. So here's the olecranon process, the epicondyles of the humerus. Okay, and you do the same thing on the other side. Pain, tenderness, heat, nodules. I don't feel any of that. So then to test for muscle strength, we're going to come right here. We're going to come down. We're going to come up. And then pronate, supinate. I think that's it for elbow. Yes. Okay. So now we go to the shoulders. You want to look if they seem symmetric bilaterally, full, everything looks good. I have no pain in my joints. So no tenderness, heat, pain, and everything seems symmetric bilaterally. I want to shrug. I want to come out to flex, back to hyperextend, adduction, no, abduction, adduction, what's that called? Oh yeah, external rotation and internal rotation. Great. And then we want to go ahead and shrug against resistance, and that also tests for spinal or cranial nerve number 11, which is spinal accessory nerve. Okay. And the muscle tone was a 5 out of 5. So I'm going to go ahead and ask my patient to stand again, and I'm going to palpate down their vertebrae, down their back, and make sure everything looks symmetrical, and the muscle structure is symmetrical bilaterally as well, and everything looks aligned. So I would flex at the waist. I would come back for hyperextension at the waist. I would bend to one side, bend to the other side, and I would rotate to the sides to test for the vertebral column and symmetry. Okay, so now I'm going to look at my hips. My hips appear symmetric and the same height to test for range of motion. This is flexing, or also that is as well. Back is hyperextension. You would have them in the prone position for that. Internal and external, you would do this the same on the other side to test for symmetry bilaterally and muscle structure bilaterally. Okay. Perfect. Oh, and then we're going to test for hip strength. So I would lift my leg and ask them to rise against resistance. Same on that side. Okay, so now we're going to palpate the knee. So you just want to feel the knee and all the joints around there, the popliteal space. Everything looks good. No heat, tenderness, any masses, no nodules as well. You want to bend back the knee for flexion, hyperextension. Could you see that? Flex, hyperextension. Okay. And then for weight bearing, you want to say that the feet are straight. There's 5 digits on each toe. Leg is, or feet are aligned with the tibia. No redness, swelling, anything of that sort. And then you would want to have the patient sit down so they're non-weight bearing, and say the same things, just that the feet have 5 digits, that there's no masses, tenderness, swelling, any redness or pain, and that everything is aligned with the tibia as well. You want to palpate the Achilles tendon on both sides, and then the metatarsal joints, which I can't really show you because I have shoes on. And then you want to, again, say there's no pain, nodules, redness, swelling, anything like that. And you want to have them lift their toes for dorsiflexion, lift their heel for plantar flexion, inversion, eversion. And then you would want them to flex their toes and extend their toes as well, but I can't show you that. Okay, so now we're moving on to our last portion of this exam, which is the neurological function. So we're going to start with a few tests before we move on to the cranial nerves. So I would have the patient sitting towards me, and I would start with a cotton swab touch. I would do this bilaterally so I could make sure that they had sensation on both sides. I would touch them lightly with a cotton wisp on upper extremities and lower extremities. This test for superficial touch. So if they were able to tell me where I was touching them, then I would say that sensation is intact bilaterally. Then we're going to test for a position. So I would lift one of their fingers and ask them how their finger moved. And I would do that on the other side, either up or down, and ask them what position I moved their finger in. And if they can ask that, then I would say that sensation is intact as well. And I guess that's kinesthetic. So next we're going to test for a familiar object. So I don't have anything on me, but say I put a pen in their hand and I had them close their eyes. If they could tell me that the object that I put in their hand is a pen, then I would say that stereogenesis is intact bilaterally, because I would do this in the other hand as well. Next, for graphesthesia, I would draw either a number or a letter in the patient's hand while they were closing their eyes, and if they could properly tell me what I did on both sides, then I would say that that sensation was intact bilaterally. Next, I'm going to test for deep reflex tendons. So the first one, I would start with the plantar. I would run the reflex hammer from my heel to the ball of my foot, and I would expect a little flexion from my foot for that reflex. And I would do that on both sides, and I would say that that sensation was intact. Then I would do the same thing with the knee. I would have the reflex hammer. Here's my patella. I would strike right below the patella on both sides, and I would expect my knee to come out like this a little bit. And if that's the same on both sides, I would say that that was intact bilaterally, or their reflex was intact bilaterally. And next would be the Achilles. So I would have my hand on the ball of their foot. I would strike with a reflex hammer on their Achilles tendon, and I would expect their foot to have a reflex. And I would do that bilaterally, so then I would say that their reflexes were intact on both sides bilaterally. Okay, and then I would test for the upper extremity coordination. So I would have the patient put their hands here on their knees, and if they were able to do that at a rapid and rhythmic pace, then I would say that their upper extremity coordination is intact bilaterally. Then I would do the Romberg test. You would do this for 30 seconds, but unfortunately I don't have time for that. So you would have the patient stand with their feet in front of them, hands to their side, close their eyes for 30 seconds. You will see a bit of swaying, but a little bit is okay. And you just want to make sure that they maintained their foot posture and their upper body stayed, they had good upright posture still, I guess. Okay, so then when the patient was coming in, you should have noticed their gait. If it was balanced, even, they didn't have any trouble stumbling or anything like that. They had good upright posture, and their arms had opposing movements. Okay, so now we will move on to the cranial nerves. So cranial nerve number 1 is olfactory. That has to do with your smell. Excuse me. So you would have the patient close one nostril and see if they could smell something from the opposing nostril. You would repeat this for the other side. Close one nostril, have them sniff something. If they can smell from both sides, then you would say cranial nerve number 1 is intact. Number 2 is your optic nerve. So you're going to perform a confrontation test and also the Snellen chart for physical acuity. So the Snellen chart is 20 feet away, and then you would see how they do on that. And then the confrontation test, I would have my patient close one eye, I would close the opposing eye, and I would ask them when they saw my finger. I would repeat this for the other side. Okay, and if they were able to do everything bilaterally, I would say that cranial nerve number 2 is intact. So we're going to test cranial nerve 3, oculomotor, cranial nerve 4, which is trochlear, and number 6, which is abducens. We're going to test all 3 of those together. So the first one that we're going to do is the 6 cardinal fields of gaze. Okay, hopefully I can show you exactly how to do this. So they would follow your finger with their eyes only. Do not move their head. And then you would bring your finger in front of their nose, okay? And you would note that there was no nystagmus, which is the shaking of the eyes or the pupils. Second, you would do the parasympathetic pupil response. You would use a pen light for this. You would shine the pen light in one eye, and it should constrict. And then you should also look at the opposing eye, and it should also constrict. And you should do the same test for the other side. And then the third is accommodation. So I would ask my patient to look at something across the room, and their pupils should dilate because distance is dilate. And then I would ask them to look at my finger. And closeness means constrict, so their pupils should constrict coming back. And if both eyes dilate and both eyes constrict, then you have accommodation. You can always use PERLA, which means pupils are equal, round, reactive to light, and have accommodation. And then you would say cranial nerves 3, 4, and 6 are intact. Now we'll test for cranial nerve 5, which is the trigeminal. You would ask the patient to open and close their mouth, clench their teeth, and again you would palpate the temporalis and masseter muscles. And then you would also use a cotton wisp and hi baby, and put it over their forehead, their paranasal sinuses, and their jawline, and you would do that bilaterally. And they should report that they have a tickling sensation when you do that. And if they pass both of those tests, then you say cranial nerve number 5 is intact. Okay, so now we're going to test for cranial nerve 7, which is the facial nerve. You're going to have the patient raise their eyebrows, close their eyes real tight, smile, show teeth, puff their cheeks. And I think there's one more. Oh yes, purse their lips. So if they're able to perform those and everything is smooth and symmetric, then you would say that the facial nerve or cranial nerve 7, the facial nerve is intact. Next, you're going to have cranial nerve number 8, which is acoustic or vestibulocochlear. You would go to one side of the patient about 2 to 3 feet away, and you would whisper a 1-syllable and then a 2-syllable word and see if they can repeat what you said. And you would move to the other side and do the same thing. Then you would also do the Weber test, and I would strike a tuning fork against my hand, and then I would put it right here on the patient's head, and I would expect them to hear the sound bilaterally and equally, and you would document yes or no for that. If the answer is yes, everything looks good, then their 8th cranial nerve, the vestibulocochlear acoustic, is intact. So now you have, oh, low battery, sorry. Okay, so cranial nerve number 9 is the glossopharyngeal, and 10 is the vagus. So what you would do is have the patient say, ah, and look for upward symmetry and movement of the uvula and the soft palate. And also you would test their gag reflex. And then, oh, there was one more. Oh yes, we also tested for the vagus and the glossopharyngeal cranial nerves when we asked the patient to rotate their head against resistance. Okay, great. So cranial nerve 11, I said earlier, when we shrug our shoulders, that was testing for the spinal accessory nerve. So you would say that cranial nerve 11 is intact. Okay, and last but not least is cranial nerve 12, which is hypoglossal. That is your tongue. So I would have my patient stick their tongue out, bring it up, bring it down, and rotate side to side, and I would note the symmetry of the tongue as well. So they would do this. Okay, and you would say cranial nerve number 12 is intact. Hopefully I got everything. I appreciate you watching my video, Miss Baxter, and I hope that you are staying safe and warm throughout the storm. Thank you so much. Have a good day.